Good afternoon, everyone. My name is Leandra Lacey, and I serve as the Senior Manager of Capacity Building and Member Engagement at the National Coalition of STD Directors, or NCSD. At NCSD, we're working to more widely promote the work of DIS and offer them opportunities to share resources via our DIS community of practice. So this webinar today, Outbreak Response from the DIS Perspective, is the second webinar of this community of practice and will hopefully be a useful learning opportunity for all of you. So just for some logistics really quickly, if you have questions or need technical help during this call, please utilize the chat function feature in the bottom right corner of your screen. You can also private message me or my colleague, Tiffany Haskell, and we're both listed as hosts on the right side of your screen. All questions will be addressed at the end, but we will keep a queue, so please send them our way as they come up. This webinar is being recorded and will be shared with all of you via the email address you register with. The recording and slides will also be posted to the NCSD website as well. And just as a reminder, you aren't able to listen only via your computer speakers. You have to dial into this webinar, and I post the dial-in information in the chat box as well. But feel free to type in the chat box if you're having any audio issues too. So the webinar today aims to highlight the specific ways in which DIS has been used to address rises in syphilis in New York State, Louisiana, and Texas. We'll also outline how DIS has been integrated into rapid response plans in these jurisdictions, and you'll also hear speakers detail how DIS has collaborated with community-based organizations to address rises in syphilis in their jurisdictions. So first, our speaker from New York State will be Kate DiBenedetto. We'll also have Ashley Larche from Louisiana, then Sydney Minnerly from Texas, and then we'll move into the Q&A period where you can submit your questions via the chat box. But as I mentioned, feel free to keep your questions coming as they come up throughout the webinar. So without further ado, I'll go ahead and introduce our first speaker, Kate DiBenedetto. She is a technical assistance representative at the New York State Department of Health/AIDS Institute. Kate provides technical assistance to HIV/STD partner services programs in the western and central New York regions of the state, such as Buffalo, Rochester, Syracuse. Previous to this position, she worked as a linkage specialist for individuals living with HIV/AIDS. Kate came to New York State Department of Health from Monroe County Department of Public Health, where she began work as a disease intervention specialist. In addition, Kate has served as an adjunct professor in the Department of Public Health and Health Education at the State University of New York College at Brockport since 2014. And take it away, Kate. Thank you.
Okay, thank you. So this is Kate in New York, and today I'll be speaking about how DIS in this region have addressed syphilis increase in Monroe County. Again, I work in the Bureau of HIV/STD Field Services, so I work with Partner Services and DIS. So just some background. In New York State, we have two health departments. We have New York State Department of Health and New York City Department of Health and Mental Hygiene. So I'm with the State Health Department, and we cover what we call upstate New York, so places like Buffalo and Syracuse. So the data that's presented in these slides are specific to upstate New York and will exclude New York City. I'm going to share statewide data, but also compare it to what we're seeing locally here in the Rochester region, where I'm located in Monroe County. So probably no surprise to those on the call, but we've been seeing an upward trend in STI diagnoses in New York State from 2014 to 2018, so among gonorrhea, chlamydia, and early syphilis for the past 5 consecutive years. And as you can see, we have seen a 57% increase in primary and secondary syphilis cases and a 200% increase in congenital syphilis diagnoses. So if we look more specifically at 2018 data, you can see that the state had a 9% increase in early syphilis cases from 2017 to 2018. Primarily, our early syphilis cases are among males, but we have seen approximately a 42% increase among females. However, if you focus and look at the Rochester region where I'm located, we've had a 78.4% increase in early syphilis cases. And we're finding a significant increase, 975%, almost 1,000% increase in females, which has been a non-traditional population when we're talking about persons who have been impacted by syphilis in recent years. So this slide depicts early syphilis rates by county, and this is specific to 2018. So the darker purple counties with the red dots signify the counties with higher syphilis rates. And here's Monroe County in the western part of the state. It sits between Buffalo and Syracuse, and we're seeing the majority of the cases within Rochester, New York, which is an urban center of Monroe County. We're seeing increases in other counties as well, as you can see down by the Pennsylvania line and down by New York City, but none as significant as the increase in Monroe. So our Bureau of Sexual Health and Epidemiology determines an outbreak by running reports on a monthly basis. They look by disease, our reportable STIs, and then they break it down regionally and by county. And then from there, they look at the number of cases that were reported year to date compared to the previous year, as well as the percent change in cases. And then more closely looking at populations such as age groups, sex, race, and ethnicity. So in New York State, we're working to strengthen our outbreak definition. It's been an ongoing discussion and really a focus of ours for 2020. So we'll be interested to hear from the other jurisdictions today and how they define outbreaks. And then also important to note is that our surveillance team really relies on communication from partner services, from DIS and their supervisors, because many times DIS are the ones who identify the increase first, just through increased case assignments, and they're also the ones who identify those impacted, just through discussions in the office and then more formally during our bi-monthly case reviews. And that's where we just discuss trends in morbidity, challenging cases, partner names, and other commonalities between cases. So this slide depicts congenital syphilis and primary and secondary syphilis cases by county, and this is from 2013 to 2018. So the darker green counties are those with increased numbers of primary and secondary cases, and the red dots signify location of congenital cases, which we had 26 between 2013 and 2018. So you would expect to see congenital syphilis in counties with higher rates of primary and secondary syphilis. Although it appears that Monroe had higher rates of primary and secondary, they were successful in averting congenital syphilis during this time frame. Unfortunately, though, this year, Monroe County had their first congenital syphilis case in years. And although the mother was in prenatal care, she was attending her provider visits and being screened, she acquired the infection late within her pregnancy. So if we look at populations affected by early syphilis in New York State, specific to 2018, you can see that Black non-Hispanic persons were 5 times more impacted by early syphilis compared to white non-Hispanics. Cases were primarily among males, with rates highest in our 25 to 29 age range, and then there's our increase in female diagnoses. However, if you were to look at Monroe County data, you would see that things look a little bit different here than rest of state. So again, we saw almost 1,000% increase in female cases, with 4 female cases in 2017 and 43 female cases in 2018. We saw 1,000% increase in females aged 30 to 34, and we saw 2,500% increase in cases among white non-Hispanic females, with 1 in 2017 and 26 in 2018. What we also know is that Monroe County has been impacted by the opioid epidemic, and we're seeing the intersection of this epidemic among our female early syphilis cases. Excuse me. This information was, of course, realized due to information that was gathered by our skilled DIS during interviews and reported through communication with each other, and then again more formally during those bi-monthly case reviews. What we also know is that many of the female early syphilis cases were among women who engaged in transactional sex, so sex for money and drugs, and primarily in a neighborhood park that's commonly associated with sex and drug use. So this brings me a little bit closer to more of the fun stuff and the specific ways that DIS were the leaders in disease outbreak response. So just some background first. During 2018, New York State Department of Health sent out a health advisory to all providers, alerting them of the increase in congenital syphilis, and this included recommendations for screening syphilis during pregnancy. However, we were really impressed with Monroe County and that they took this advisory one step further and followed up locally with their providers with a series of letters. So the first was a follow-up letter directly to their primary care physicians, providing them with more specific local data regarding the significant increase in their area. But they also shared the CDC recommendations and asked to consider retesting during early in the third trimester in addition to the first trimester and delivery among all pregnant women, not just those at high risk. And that's just due to the local prevalence of disease among females. A week later, due to the realization that many of the females infected were persons who inject drugs, the county sent out another Dear Colleague letter to their community substance use providers to screen patients upon entry to those facilities. And in that letter, they also offered education regarding syphilis and promoting partner services. And then early this year in 2019, they sent out another letter to all providers with full 2018 syphilis data and just reminding providers of their responsibility to report, treat sexual partners, and screen pregnant women as recommended. And then just more recently, the county, DIS, and their supervisors have asked that their local county jail medical team request that individuals be screened upon entry to the jail if they were incarcerated due to drug or prostitution charges. So as all of this was happening, DIS were the ones who were recognizing who was most affected in their area: female sex workers who injected drugs in multiple neighborhoods of the city, and DIS were the ones that led the response to address the increase in the cases among these women. So as DIS were out in the field conducting field visits for interview and notifications, as usual, they were also stopping at organizations within the neighborhood surrounding that park, to churches, businesses, substance use providers, and educating them of the increase in syphilis in the area. And then through these relationships, they were able to acquire donated spaces to bring the STI testing directly into those neighborhoods affected. And this was primarily through local churches and recovery houses. So once the space was identified to hold the testing events, DIS reached out to other CBOs, such as federally qualified health centers, needle exchange, recovery homes, health insurance providers, other supportive services. And they brought all those CBOs together and led a planning meeting prior to these testing events, just to establish each agency's role at the event. Also, prior to the events, while DIS were in the field, they were also promoting the event by posting flyers around the park, in the community, at local businesses, promoting on Facebook, and then going out and reminding the sex workers the day before that they would be out testing in the community. In addition to that, DIS also helped to collect food, clothing, create care packages to provide during the event. And this was done through themselves, their family, their friends, and other people at the Department of Health. And we held these events during different seasons of the year. So as you know, in New York, many of the months here are cold. So having hot beverages and warm clothing available was helpful. The day of the event, DIS were the ones who led the event. They really did it all. They helped with setup and cleanup. They ensured that the CBOs had their space to provide services. They're the ones who conducted the outreach in the streets to bring the women in for testing. They went out with Narcan trainers to bring Narcan training into the streets. They managed the intake process. They assisted individuals with filling out the intake forms. And they assisted the public health nurses with HIV and STI screening, including extragenital self-swab screenings. And they handed out safe sex supplies and personal care items. So some of the challenges, due to the severity of the drug use, we found it challenging sometimes to bring the girls in for testing, to sit there and wait while in withdrawal. So it was really important that we had multiple testers on site so that we could expedite those walk-ins and just be flexible and compassionate if the women needed to leave and come back at a later time. Initially, we had tried scheduling events for mid-morning, but we ended up switching the time to early afternoon to accommodate the women's schedules. Where we found success was pairing the testing events during the same time as when the churches were holding their food cupboards. This just increased traffic in the church and increased the number tested. Another lesson learned, like I mentioned, all those extra supportive services, the warm clothing, the food, the Narcan training, that's what brought the women in to the church. And then from there, we were able to encourage them to get tested. So having those extra perks available was really helpful. And our biggest success was that while we were out conducting outreach, trying to bring women in for testing, we came across people that we had been looking for that had been assigned to us as a case, who were previously unable to locate, who weren't responding, and needed treatment for STIs. So I just want to thank our DIS in this Rochester region. This was truly a collaboration between county and state DIS workers, so our Monroe County DIS as well as our Rochester region DIS, and we're just really grateful that we have a team here that works really closely together. And then, of course, to our Bureau of Sexual Health and Epidemiology and our Bureau of HIV/STD Field Services for their support and providing the data for this presentation. So from there, I'll say thank you and send it off to Leandra.
Thanks, Kate. That was awesome. Just a reminder that if you do have questions for Kate or any of our following two speakers, please put them in the chat box, and we will address all of them at the end just to make sure we'll have enough time to address everything. So we appreciate the questions that are already coming through. So next we'll have Ashley Larche, who serves as a lead field operations specialist at the Louisiana Department of Health, Office of Public Health, within the STD/HIV program. Ashley began her work in public health as a DIS in 2009. Her primary roles are quality assurance of DIS cases, quality improvement, collaboration with the perinatal supervisor to oversee congenital syphilis case reviews, and capacity building and training for DIS staff. Ashley is an active member of the program's Health Equity Action Team. Her academic background includes a BS in psychology from Louisiana State University and an MA in counseling from Xavier University. Take it away, Ashley.
Good afternoon, everybody. I'm happy to talk with you all today about the outbreak response from the DIS perspective here in Louisiana. I'm very happy to contribute to this conversation, and a lot of what Kate said, it looks the same way here in Louisiana. Oftentimes the DIS are the front lines here, as far as outbreak response is concerned. So I'll speak a little bit about what that looks like. I'll talk a little bit about our landscape here in Louisiana, how we identify outbreaks and what the response looks like as it relates to DIS. And I'll talk a little bit about one example that we've had in a region in our state and how we approached that. So Louisiana is divided into 9 public health regions. Each region has a DIS supervisor. So we have 9 DIS supervisors, 25 DIS, and there are 3 main central office staff persons here who provide technical assistance to the DIS. So we programmatically supervise all the DIS across the regions, and they all conduct investigations for syphilis and HIV, and also cases of HIV and gonorrhea comorbidity. And as you can see, Region 6, where I'll talk about the one outbreak example, is in the central part of our state. It's more rural than some of our other regions, so it was quite interesting to see the uptick that we saw in cases between 2017 and 2018. So in general, we noticed that, we can use surveillance data to identify outbreaks. We don't have any staff here at our central office who are specifically dedicated to identifying outbreaks, but we regularly monitor the data. Oftentimes, as Kate said, the DIS are the first ones to realize that an outbreak may be occurring, and they may notice it in a few ways. They may notice that they have increased caseloads, and they may also notice an increase in symptomatic patients who are coming into the clinics as walk-ins and or referrals. And our DIS are housed in parish health units across the state. Of course, in Louisiana, we have parishes instead of counties. So they are housed in the parish health units, and many of those health units do still take walk-ins. Many do operate by appointments, but during an outbreak, one of the things that we try to do is make sure that those parish health units are regularly taking walk-ins. Another thing that the DIS often notice in their interviews are changes in risk behavior, changes in drug use and how it relates to folks' sexual practices. So, yeah, and usually the DIS are often the first to recognize that there's an outbreak. With our surveillance data, particularly when there is an outbreak, there are several things that we all come together to look at. We look at the demographics of the people who are, experiencing the increases. We look at risk behaviors, HIV status, and our co-infection rate. We look at rates of acute HIV infection. We look at the percentages of people who are living with HIV in an area who are virally suppressed and who are linked to HIV care within 90 days of HIV diagnosis. And we also look at what providers are our primary testing providers and treating providers to try to identify any issues there are around providers who may have trouble treating or who may be making referrals out to other places for treatment. Right now, we have no specific threshold that would signify an outbreak, but our team of epidemiologists here, when they do spot significant increase, they notify our field operations unit. And oftentimes it does confirm what the DIS are asserting is going on in their respective areas. So some ways that we respond to outbreaks with the DIS, and of course here in Louisiana we try to have the most impact that we can with limited resources. So we work to reassess work distribution within a region. Some of our regions work in a way where certain DIS work certain areas or certain zip codes, and sometimes during an outbreak, some of those practices need to be reassessed, and we also temporarily reallocate resources if needed. So in the case of the outbreak in Region 6, we did make a voluntary call out across the state for regional field assistance to report to the location of the outbreak. In this particular area in Region 6, we only had 2 DIS staff who were working at the time of the outbreak. So one of the things that was needed was just additional boots on the ground. So we made a voluntary call out to DIS, and we had DIS travel to that area to assist the DIS in that area. From the central office here, we took some of the workload off of the frontline supervisors by assisting with case closure virtually, and then also sending staff from our central office to work in the location of the outbreak as well. I'll show you an example of a provider alert letter that was also sent out on the next slide. Another aspect of provider outreach to assist with outbreak response. In each of our 9 public health regions, we have what's called regional task forces, and these task forces meet at least quarterly throughout the year, and they're comprised of community-based organizations, providers, and advocates around STD and HIV work, and their primary goal is to create and implement activities that are outlined by work plans to decrease rates of STD and HIV in their areas. So whenever an outbreak occurs, and this also happened with the Region 6 outbreak, the information goes out to the community through the alert letter, but also through those regional task forces to essentially get the word out. We also use zip code level data to drive decisions about the distribution of DIS work. And while response can look different depending on the resources, the general approach is essentially the same with that. As it relates to the approach with congenital syphilis, one thing that we've done is to ensure that the DIS verify all 3 sets of bacillin injections if needed before a field record is closed. And that's just more of an aggressive approach to reducing the number of CF cases that may be due to previously untreated or inadequately treated syphilis. Our DIS collaborate with our congenital syphilis case managers. We have 2 in the state for more long-term follow-up of women of childbearing age, and they also collaborate with staff who are called linkage to care coordinators, and they work in various parts of the state, and their primary job is to re-engage people who have been lost to follow-up for HIV care. But during an outbreak, all of these folks come together to talk about what they can all do to leverage all of the resources they have to approach the outbreak. On this next slide, this is an example of the public health alert letter that went out to the Region 6 area with this syphilis and HIV outbreak. And the alert letter is sent out by the state health officer. It includes surveillance data related to the outbreak. It includes recommendations for providers and community-based organizations to increase screening, testing, and treatment in their practices. And there are reminders for clinicians to screen women with syphilis in pregnancy, and we also have a syphilis during pregnancy reporting form that providers send in here to central office. It also directs providers to the CDC website and the Denver PTC for any consultative needs around diagnosis and treatment of syphilis. On this next slide, it is a bit data heavy, but these outline what we saw with our Central Louisiana or Region 6 outbreak in 2017-2018. So we saw an uptake in symptomatic and asymptomatic early cases of syphilis. They more than doubled in Region 6 between 2017 and 2018. Early non-PNS syphilis cases had increased by 63%. Also, the number of HIV diagnoses increased by 80% between 2017 and 2018. It increased from 39 cases in 2017 to 70 cases in 2018. And nearly 2/3 of 700 cases reported illegal drug use. Of those, 56% reported recent use of crack, cocaine, and methamphetamine. And among the new HIV diagnoses that reported illegal drug use, 46% reported cocaine use, and another 46% reported methamphetamine use. The population was primarily high risk and vulnerable. 25% of all cases traded money, drugs, or shelter for sex. And the congenital syphilis cases in that area increased by 400% from 1 case in 2017 to 4 cases in 2018. Over 20% of persons with an early syphilis diagnosis and 12% of persons with a late syphilis diagnosis in 2018 were co-infected with HIV, and 40% of the co-infected persons were not virally suppressed. And lastly, 66% of the HIV co-infected persons had been diagnosed with HIV at least 1 year prior to their syphilis diagnosis, indicating ongoing sexual risk behaviors. And generally what we noticed that worked for us is we do regularly have calls with the frontline supervisors in all of the 9 regions. We have those calls monthly. And on those calls, we encourage the supervisors to talk about any changes that they've noticed in their area, and we, will then request surveillance data to kind of confirm whether or not there is some sort of increase. So we keep those lines of communication open, but once we identify an outbreak, we have more regular meetings, and we also invite the DIS to participate in those central office meetings where we're reviewing data and making a rapid response plan for that specific area. We also make contact with the community-based organizations, especially the ones who test and treat, and we always empower our field staff to voice anything that they notice that's going on with providers, providers who may not necessarily be following the recommendations for testing and treating. We also notify the clinical staff of a possible need to take more walk-ins, and especially when we're deploying more staff to those areas, they may see an increase in the number of walk-ins when more DIS are out in the field conducting rapid tests, referring people into the clinic. So we give those clinics a heads up just so that they don't turn any people away when they're coming in to be tested or treated. And we also cross-train staff just so that we can, if we can, take some of the office work away from the DIS so the DIS can go out in the field and refer people in to, again, have the most impact with our resources. And that is it for my presentation. Thank you.
Thanks so much, Ashley. Again, everyone, I see that there are still questions rolling in. Keep those coming, and we will address those at the end for all of the presenters. So next we'll have Sydney Minnerly from Ashley's geographic neighbor in Texas. Sydney serves as the Partner Services Coordinator for the Texas Department of State Health Services for 8 years, or she did serve in that position for 8 years. Her role consisted of providing guidance and support to the 18 public health jurisdictions in Texas, which perform partner services, also known as public health follow-up, and STD surveillance activities. She has experience in policy development surrounding syphilis and HIV response, and she served as a subject matter expert in the development of Texas' new STD data management system to improve timeliness of disease reporting and partner services activities. She has worked in the HIV/STD prevention field for over 24 years, and she was recently promoted to the manager of STD prevention for the Texas Department of State Health Services. Take it away, Sydney.
Well, thank you. And the only reason why I'm here to present is because Louisiana gives Texas all of its morbidity. So just wanted to put that out there for y'all. Good afternoon, everybody. Again, my name is Sydney Minnerly. I am the STD Prevention Program Manager for the Texas Department of State Health Services. And I am going to talk to you about what our activities are when it comes to outbreak response. And we call it rapid response, and we have a specialized team associated with it. Many of you all are familiar with the way Texas is set up, but just in case you're new to this conversation, Texas is comprised of 254 counties. We don't have parishes like our neighbor, but it is a vast geographical and diverse population that we serve. We serve over 28 million people with the services that we provide. Just so you know, we are the home of the mockingbird, bluebonnets, and pecan pie. We're also the home of fried bubblegum, butter, and beer. So in case you're hungry, you know where to come. We have over 13 million cows, and that's about 13% of the nation's cow population. So that's exciting. And with that, we also have plenty of STDs. We report over 140,000 cases of chlamydia, about 45,000 cases of gonorrhea. This past year, we almost had 12,000 cases of total syphilis, and 6,000 of those are considered to be early or primary secondary cases. Every year, we report about 4,300 cases of new diagnosis of HIV. We are a decentralized state, meaning that we do have DIS who are located within the local health departments as well as in regional health departments, with oversight from our central office, which is located in Austin, Texas. So we do fund 8 local health departments, but we have activities or public health follow-up activities going on in 10 different local health departments, and we have 8 regional health departments that we also work with. The local health departments generally are the ones who cover the larger metropolitan areas, and our 8 regional health departments are generally tasked with the counties that surround those local health departments or major metropolitan areas. And so when we're talking about regional health departments, they can cover up to 42 different counties and have a large geographic area that they need to cover, and it tends to be a lot more rural in the aspects they cover. In Texas, we have approximately 120 positions of DIS that are across the state, and at any given time, we operate at about 75 to 80% or 85% capacity. Some of that is attributed to the different hiring freezes and or issues that we have when it comes to staff turnover. I'm sure none of you all experience staff turnover when it comes to DIS specialization. So as you can see, this is kind of the trends that our syphilis cases for primary and secondary has gone along. You can see we had a small dip right around the 2009-2010 era. That's when we were starting to really focus in on our syphilis elimination plans and working towards that goal. And then the Texas Department of State Health Services hired me, and all of a sudden we started going back up in number of cases. So that's kind of disappointing. That's definitely going the wrong direction. That's not something that we're interested in doing. When it comes to our morbidity, you can see that generally speaking, our morbidity is reported primarily east of what we call I-35 corridor, which runs through the central Texas. Anything east of that would be your Houston areas and definitely our larger metropolitan areas. Now, you may see some of these counties that have orange blocks on the western side of Texas. Those tend to have fewer people living there, and they do have, again, those cows that we referenced earlier. But because they have fewer people, their morbidity and incident rates tend to pique interest. So when we're talking about what an outbreak is, especially when it comes to Texas, you look it up and it says, oh, it's a sudden rise in disease. And I really think that that's a pretty boring definition of what an outbreak is. It doesn't sound nearly as exciting as it should be. So then I looked up another one, and it says there's just more cases of disease than expected. And I think, well, okay, well, that's helpful, and we're getting closer to what we really want to get at. But as far as Texas is concerned, and specifically when we're talking about outbreak response in regards to syphilis, we have defined it as a sustained increase in early syphilis of greater than 2 standard deviations over the past 6 months. So what we're referencing is that we're trying to look at the number of cases that we're seen for the past 3 years. And what we want to see is we want to see if this is something that is generating a need for response, and if it's sustained, then that means that we are it's not just a blip in the disease or incidence of infection, but it is something that we can actually do something about. Now, when you're talking about Texas, we also want to be mindful that we do have counties that have never reported a case, and then all of a sudden they have 1 case, which could trigger representation that is greater than 2 standard deviations about, from their past 36 months. Sorry about that. We definitely take that into consideration when we're doing our evaluation. So let's talk about our process and what we actually do. So first what we do is we identify an outbreak. And then from there, we start working with our jurisdictions and sites. As I mentioned earlier, we have 18 jurisdictions that we work with on a routine basis, partner services and public health follow-up. Then we actually have the opportunity to have conversations about whether or not there's a need for a deployment of a team. And then we have to do follow-up monitoring to make sure that we have actually successfully addressed the increase in disease. So the first thing that we do is that we actually run a threshold report. And what we do is we look at this biweekly. It's a report that is run by our epidemiologist through our data management system, which used to be STD-MIS until about 6 months ago, which turned into Thesis. And then she works through SAS, and she has code for that we can share if folks are interested in that. It is based on morbidity that is reported through the DIS, and that's a caveat to the quality of data. For instance, if the DIS decides that they're not going to associate morbidity with their investigations, then we don't actually get information about that increase in morbidity. Another thing as well is that we rely heavily on the correct case classification from the investigations that occur. We do have our threshold report distinguished between the different stages. We primarily look at primary and secondary cases, and the reason why we look at that is those are easily defined with symptoms and history. We also take a look at early non-primary, non-secondary cases because, again, those indicate that this is a new infection or this is something that has occurred within the last year. One of the things that Texas does is that when we get a report of a syphilis infection, we run those interviews and cases as if they're early cases, and so that we can treat the infection and the investigation as urgent. And it tends to be a little bit less reliable when we run our morbidity report or our threshold report on looking at the 730s or the case classifications of the very non-primary cases. It's a little bit more volatile, and eventually some of those cases end up changing to a case classification of an administration. We do break up this report in 3 different ways. We look at the county level, so it's good for us to see, as smaller counties are usually reflective of disease shifts. When we have larger morbidity areas, it's not as easy to see those disease trends coming out in this biweekly report. We also do it by surveillance or public health follow-up area. Our jurisdictions are not strictly restricted to a county level. We have several local health departments that serve multiple county areas. If they serve multiple county areas, then that public health follow-up area would be more reflective of what's going on in their public health follow-up jurisdiction. And then we also do it by region. So our regions are split out by the 8 different public health follow-up regions, which include those larger metropolitan areas in addition to the rural areas. And then when we look at the threshold report as it comes out, it triggers a rapid response, or it might trigger a warning. A warning is something that says, hey, you guys may want to take a look at this. You may want to see what's happening. You may want to investigate. And sometimes a warning is actually a precursor to what we would call a rapid response alert. When we look at the rapid response alert, then we would look to see if this is something that has occurred over multiple threshold reports. If it has, this is where the analysis and review from central office staff actually begins to occur. Again, sometimes we get a rapid response alert when a county experiences one primary syphilis case that can be attributed to a larger metropolitan area in the area. So I just want to sing here for a second and make sure that everybody's still with me. So we're going to say, can we just talk? Can we just talk? So we're going to talk about, not love this time, but so the central office does their notification and review of the threshold report, and that's done by our consultant who is in charge of our quality improvement and quality assurance. in rapid response team. The consultant that's in charge with that program is then notified. Once that consultant has been notified, then we also work with notifying the jurisdiction or site. And as was mentioned earlier, sometimes field staff are much more alert and much more attuned to what's going on when it comes to different things that are happening in their area, and sometimes we get surprised. We definitely have a centralized system that people report in, and sometimes morbidity gets reported to a jurisdiction that they are not necessarily aware has occurred because the interview may have happened in a prison or the interview may have happened in a county outlying the area. And then we do some case analysis. We do that with the jurisdiction, and we try to figure out what do these cases have in common, what are some of the common risk factors, where do they hang out, what's the zip code that they live in, what apps do they use, is there a demographic or substance use commonality things that are going on. And sometimes we work with the sites on actually getting what we call a visual case relationship analysis or sociosexual network mapped out for them. And we definitely make sure that they can see where they need to focus their efforts. With our rapid response coordinator, we review the site's rapid response plan. This is something that they have to have updated annually, and they have to submit it to the central office. And this generally contains the information of what they would like to do if they all of a sudden saw an increase in cases in their area. Then we start working with identifying resources that are available to them. And then we work with the jurisdiction on deploying a team and working with them on that. So some of the resources that we actually deploy, definitely our biggest issue or thing that we deploy is staff. This can include frontline DIS, first-line supervisors. We've also deployed surveillance staff as well as nurses. The DIS are typically identified as persons who are successful in meeting their program objectives in the form of their performance indicators. So when you're talking about your contact index or your cluster index, making sure that they adhere to the standard documentation, that they're actually really successful in their current program, that they have to be fluid in new environments, independent, flexible, and team-oriented. All of our DIS are required to be trained in phlebotomy, but often the staff are also able to perform point-of-care testing for HIV, syphilis, and hepatitis C when it's applicable. We also have deployed clinical staff, and not only just to staff clinics, but also to work with sites on the evaluation of their clinical practices, whether their clinic hours are actually impacting the services that are rendered, working with appointments and other barriers to care. We have media spots. We've done radio spots, TV ads, app banners. We've supported billboards and also created a centralized website for persons to locate services in their area. And then we have communications, and this is where it's kind of related to the media, but it's a little bit different in that it's specific to the Dear Colleague letters, any kind of articles or television or public information that we'd like to present to the So some of the areas that we've actually applied these have been what we call the Golden Triangle, which is just outside of Houston. It's the Beaumont and Port Arthur area. We had an increase in the number of heterosexual cases, and some of the issues that we identified within that area is that they had barriers to care, they had barriers in access to care. They decided that they were going to open up their clinic for more hours and get more nurses in that. And that helped with leadership getting buy-in as well. We've also had outbreaks and responses in Northeast Texas, and when I said that it came from Louisiana, I wasn't joking. No, I was joking. Our Louisiana's and Arkansas came from Texas. We share a corner of our state with those two, and we saw an increase in the cross-jurisdictional, and so we had a tri-state response back in 2008 and 2009. We've done this kind of response in the Metroplex or the Dallas-Fort Worth area. That one was based on zip code, more so than it was based on actual risk factors. We've also done it in Houston, and Houston has been very proactive in adopting more activities outside of rapid response to decrease the number of cases. Now we've also had similar outbreaks in West Texas as well. So some of the challenges that we've had to come up against include kittens. You always have to be mindful of kittens. They can be very, very deceptive and dangerous. But then we also have to figure out where we're going to get funding and leadership support for deploying these teams. We've been lucky in that we've been able to identify that. Leadership support is also when we call on the DIS from other programs, we need to make sure that their leadership is aware and is open to sending their staff to these responses. Staff resources can be a stretch. We've run into issues in the past where staff have been, programs have been short-staffed or have not been fully available, and what do you do in that situation? Media attention, always good and always bad. People end up having a little bit of anxiety when it comes to drawing more attention to the service that we provide and the increases in disease. It also generates an increase in workload. So if you have really good DIS that are really good about initiating contact, they're going to create more workload, and that may be the workload that is left there after the deployment has ended. We have to make sure that we do monitoring and follow-up with the programs, make sure that we've addressed it. We also want to make sure that we are mindful of other priorities. We have a lot of emergency responses that occur, particularly when the Gulf Coast gets involved in hurricane response. They may not be as available and or may not be able to host rapid response team. Sustained increases that are not actually outbreaks. I mean, across the country, we've seen an increase in syphilis cases. That does not necessarily mean that it's an outbreak, and sustained increases have different responses than actual outbreaks do. So you have to be mindful of that as well. All right. So my question is, you have you got RRT, or Rapid Response Team. So thank you very much.
Thanks so much, Sydney, and thanks to all of our presenters today. Before we jump into the Q&A, I just want to make sure everyone's aware of the DIS Slack workspace that NCSC has. Slack is the communication platform for our DIS community of practice, where you can chat with DIS across the country and share resources on a variety of topics from field safety to technology and partner services. So if you'd like to join Slack, you can use the link that will be in the slide deck. It's also here, and my colleague will also post it in the chat box. And you can also let me know if you have any questions related to Slack. My email address is on this slide, along with the email addresses for the other presenters. So now I'll read aloud some of the questions that we received in the chat box. And what I'll also do is unmute everyone's lines. You can also speak over the phone line if we have time after addressing the chat box questions to ask your question that way. Give me 1 second. Okay, perfect. So the first question that we had was from Lydia, and it was for Kate in New York State during your presentation. She asked, what drugs were the most commonly used with the community that you were mentioning?
Which drugs were the most used?
Yes.
Heroin and cocaine, or crack.
Okay. Thanks, Kate. We also had a question from Elizabeth. She said, are you doing rapid syphilis testing, and were you providing treatment at the events that you mentioned, Kate, during your presentation?
Yeah, so they were offering rapid testing as well as blood draws, and sometimes it just depended on the person. So for example, if it was someone who injected drugs, they may have had tough veins to get to, so using rapid tests, just a finger prick for those. But if someone came back positive on a rapid, then we were able to draw blood, and then the lab would actually come at the end of the event and pick up the specimens and take them to the lab to be processed.
Awesome.
Treatment was not provided at the on-site.
What manufacturer are you using for the rapid syphilis testing? Someone just asked that.
Ooh, I don't have that in front of me, but if you want to send me an email, I can definitely
This is Veronica.
It scared me.
Let's make them do for you, either.
Okay, thank you so much for those answers, Kate. We also had a question from Nina. Let me get that really quickly. One second. So Nina asked, how did you identify the syphilis outbreak in New York State? What was the process and method in doing so? And she said, forgive me if you did address it during your presentation, but could you briefly go over that?
Yeah, so more formally, our surveillance unit pulls reports on a monthly basis, and they're looking at the cases year to date versus the previous year, and also the percent change. And then they kind of narrow it down by region and county, and then by population. And then, of course, a lot of it is relying on DIS, because they're the ones most of the time that are reporting it to us, that they're seeing an increase.
Awesome. Okay, thank you, Kate. One last question for you specifically. Tandy asked, did you already have a relationship with the churches where you did the screening event prior to identifying the need for screening in that area? How was that relationship developed?
Okay, so previous to the events, no, we did not have a relationship with the churches, but the church was located like directly in that park where the women were working, and we would see them going in and out of that church, so we knew they would go in there and receive services from that church for other things. So no, it was just kind of going in, introducing ourselves, what our role was in the community, and educating the church about what was happening, and then just honestly asking if they would be interested in donating space, and they're just very willing, even to provide food and other resources that day. And it helped that the women working in that park already had a relationship with that church, so they felt that they were welcome in there.
Thank you so much for that. Just for the sake of time, we did have a lot of questions in the chat box, and thank you so much for all of those. I do want to ask one question that was presented for all of the presenters, so we can get all of you to answer it. A question from Kira. It says, were any new guidelines regarding field-developed therapy, standing orders for treatment, or EPT policies developed as a result of or during the outbreak that you all talked about in New York, Louisiana, or Texas?
This is Sydney from Texas. We did not necessarily develop any new guidelines when it comes to field-delivered therapy. We have different jurisdictions that have had history with doing field-delivered therapy. We definitely have laws that support EPT as a clinic. And then in addition to that, in some of our more rural areas, when we've had outbreaks, we've employed actual field nurses that go out with us during the response.
That will be here Friday. Thank you so much, Sydney. Did anyone else want to answer that question, either Kate or Ashley, about if any new protocols or if any orders came out of the outbreaks or, were developed kind of during the outbreaks as they were going on?
Hi, this is Ashley. I can add, we do have the SHOT program that is actually being piloted in multiple regions across our state, and it's Syphilis Home Observed Therapy Program. And so we're using our public health nurses to go out to the homes of pregnant moms who need to be treated for syphilis, and those public health nurses, they do have a protocol set up to where they could treat a partner if the partner is also present at the home. So the planning and development of that project was going on at the same time as the Region 6 outbreak, and Region 6 is actually one of the regions in where we're piloting the shot program. So we have seen some success, and again, that's pregnant women being treated in their home along with their partners.
Thank you so much, Ashley, and a special thank you again to all three of our presenters. You all were fantastic. My colleague Tiffany has placed the link to the evaluation for this webinar into the chat box. You'll also be redirected to it once I close the webinar. And please complete that evaluation. It will really help to inform future webinars of the Community of Practice for DIS. And as a reminder, the recording of this webinar and the slides will be sent out to all those who registered and will also be on the NCSU website. Please feel free to reach out to the presenters if we did not get to your question. My apologies. I wish we could get to all of them. They were really great questions. But feel free to reach out to the presenters directly, or if you have questions for me at NCSB, let me know. I see that some of you have already joined Slack, so that's awesome. Please continue to do that as well. And thank you so much, everyone. Have a wonderful day, and I hope you found this useful and valuable. Have a good one.
Thanks, Sandra.